Question 1. A 65-year-old man presented via his GP to the acute medical unit with shortness of breath and palpitations. He had a significant past psychiatric history of vascular dementia and an organic psychotic disorder. Currently, he was mentally stable and under the care of the community mental health team and was taking amisulpride 150 mg at night. A 12-lead ECG showed atrial fibrillation, AF, with a fast ventricular response, which was not present on an ECG performed 2 days ago. The QTC was 460 milliseconds. With regards to the management of this patient's new onset AF, what is the pharmacological agent of choice? A. Amiodarone. B. Digoxin. C. Diltiazem. D. Sotalol. E. Verapamil. The answer is B. Digoxin. Summary. All antipsychotic drugs have the potential to prolong the QTC interval. Serious drug interactions that further prolong the QTC interval and increase the risk of torsade D points can occur particularly when using cardiac agents in patients taking antipsychotic drugs. Sotalol or amiodarone should never be used in combination with amisulpride, an antipsychotic. However, alternative beta blockers such as atenolol or bisoprolol are safe and often first-line pharmacological agents in the management of AF. Diltiazem and verapamil when co-prescribed with amisulpride can increase toxicity by pharmacodynamic synergism and also increase the risk of QTC prolongation. In this situation, therefore, digoxin, which does not interact with psychiatric drugs, would be the safest and preferred rate-controlling medication of choice. Question 2. A 43-year-old woman attended the emergency department with her brother following a fit. She had a history of medically unexplained seizures. She was observed frequently going in and out of the waiting room to have a cigarette as she was agitated by having to wait. As she returned to the reception, she collapsed and began convulsing. It was observed that during the seizure she had been incontinent and had hurt her forehead on a chair. She was moved into the resuscitation area and tolerated the insertion of an oropharyngeal airway. The seizure was ongoing at 5 minutes from onset. Which of the following is the most appropriate next step? CT scan of head. B. Explain to her brother that the symptoms are self-induced. C. Intravenous diazepam. D. Observe but reassure her brother that symptoms will resolve quickly. E. Reassure the patient that there is definitely not an organic cause. The answer is C. Intravenous diazepam. Dissociative seizures or pseudoseizures are psychologically mediated episodes of altered awareness and behavior that may mimic any type of epilepsy. The prevalence of DSs has been estimated as between 2 and 33 per 100,000. Around 3/4 of patients are female. Seizures typically begin in the late teens or early 20s, but there is a wide range. Seizures have typically been present for 3 or 4 years before the correct diagnosis is made. Probably no more than 15 or 20% of patients with DSs also have epileptic seizures. Question 3. A 23-year-old chef came to the acute medicine follow-up clinic. He presented with a single generalized tonic-clonic seizure. As an outpatient, He was investigated with an MRI scan of the brain and EEG, which were normal. How long does the Driver and Vehicle Licensing Agency, DVLA, state he cannot drive a car? 3 months. B. 6 months. C. 9 months. D. 12 months. E. 18 months. The answer is B. 6 months after a single unprovoked seizure. After a single unprovoked seizure, the DVLA require patients to refrain from driving a car for 6 months as long as the risk of seizure recurrence is felt to be low, i.e. less than 20% annual risk. The most significant factors in predicting recurrence are the presence of relevant structural abnormality of the brain on imaging and definite epileptiform activity on EEG. This patient is therefore low risk. If this patient had had a Group 2 license, then he would have had to be seizure-free for 5 years, have an estimated annual recurrence risk of less than 2%, have been free from any anti-epileptic medication for 5 years. If these conditions are not met or there has been a history of more than one seizure within the past 5 years, then the DVLA guidelines for epilepsy apply. Essentially, for a Group 1 license the patient must be seizure-free for 1 year, and for a Group 2 license the patient must have been seizure and anti-epileptic free for 10 years. It is important to note that these rules apply to all types of seizure, including AURAS, whether they impair consciousness or not. There are exceptions to these rules with regard to seizures provoked by other medical conditions or procedures, seizures related to medication adjustment, and those that occur only during or arising from sleep. Some situations are considered only on a case-by-case basis. There are separate regulations with regard to solitary and recurrent episodes of altered consciousness of uncertain origin, where the driving regulations vary depending on the presence or absence of any seizure markers in the history. The factors to be considered are absence of reliable prodromal symptoms, unconsciousness for more than 5 minutes, amnesia for longer than 5 minutes, sustaining injury, tongue biting,